Good morning, everyone. I am Dr. Umang Agarwal, Senior Resident, Department of Urology, presenting the case for the clinical grand round today from Department of Urology. Starting with the case, we will be discussing the case details, diagnosis, the surgical management, the pathology, and the follow-up of the case, and a short discussion of the case. So, moving on to the patient particulars, Miss X, 30-year-old female, a resident of Haridwar, presented with a pain in the left side of the abdomen for past 4 months. Pain was insidious in onset, dull aching, non-radiating, intermittent, and but was not associated with any aggravating or relieving factors. There were no associated symptoms of burning micturition, fever, lower urinary tract symptoms, trauma, altered bowel bladder habits. In the past history, patient had history of sudden onset of weakness with deviation of face associated with dizziness and palpitation episode 4 years back. For that, she took treatment at the outside local hospital where she was started on antihypertensives and her symptoms resolved after 10 days. She didn't undergo any workup for that. And this time she presented for abdominal pain. There was no history of any blurring of vision, sweating, palpitations currently, no history of any frequent diarrhea, skin changes, weight loss, hirsutism or weight gain. In the family history, she is a married woman with 3 living issues, and history of oligomenorrhea for 1 year and amenorrhea for past 3 months was there. Moving on to the examination findings. On examination, patient was hypertensive with BP of 140 and 90 in the standing position, and in supine position it was 140 by 100. Apart from that, general examination was unremarkable. On per abdomen examination, there was a hard lump palpable.
Yes, ma'am.
On per abdomen examination, there was a hard lump palpable in the hypochondrium, left lumbar and umbilical region. The surface was smooth and it was hard in consistency. The margins were ill-defined and superior margin could not be reached. Rest of the systemic examination was normal. CNS examination was normal with no focal neurological deficit, and power was normal in all 4 rooms. General lab investigations that we did were all normal, and following that, we got one patient presented with one ultrasound done from outside that was suggestive of one suprarenal mass. So we did CECT oval abdomen with adrenal protocol for the patient. That DICOM images are there that will be discussed by the radiology resident, Dr. Trilocha.
Good morning, everyone. I'm Dr. Trilocha, JR3 from Radiology Department. CCT abdomen of the patient was done in our department on 2nd of April 2022. These are the non-contrast images. Here we can see a large lobulated lesion on left subdiaphragmatic region, and it is extending into the lumbar region also. And we can see this lobulated lesion has few areas of calcifications within. Further, we will be discussing about this lesion on post-contrast images. These are the post-contrast images. On post-contrast images, this lobulated lesion shows heterogeneous enhancement with non-enhancing areas within. These are the non-enhancing areas. And this lesion has completely replaced the left adrenal gland, and it is displacing the left kidney inferiorly and medially, whereas this is the right adrenal gland, which is seen normally. Now, talking about the relation of this lesion, anteriorly it is compressing and averting the large bowel loop, and adjacent small bowel loops. However, there is no significant dilatation suggestive of obstruction. Posteriorly, it is averting the abdominal wall, and posteriorly and laterally. Medially, the lesion is also compressing and averting the tail and body region of the pancreas. However, there is no any obvious infiltration. Further superiorly, this lesion is compressing and displacing the spleen anteriorly. The lesion also shows it is also averting the stomach with loss of fat burn. However, no obvious infiltration is seen with it. Now, talking about the vascular relation, this splenic vein, the lesion is averting the splenic vein near its hilum. However, post-contrast opacification is maintained, and rest of the vascular structure shows normal contrast opacification and is seen free from the lesion. So, summing up the finding, heterogeneously enhancing neoplastic lobulated mass lesion, completely replacing the left adrenal gland and showing foci of calcification, and with extension with all this, we give the diagnosis and we give the probable diagnosis of this neoplastic lesion is adrenocortical carcinoma. Thank you.
Thank you, Dr. Throshan. Following CT of the abdomen with adrenal protocol associated with CCT neck and thorax that was not suggestive of any metastasis present, we proceeded with the functional evaluation of the adrenal tumor. Since the patient had history of hypertension and it was likely a adrenal mass, we did this functional workup to rule out pheochromocytoma, to rule out any cortisol secreting mass, and to rule out any androgen secreting mass. For that we did. In that we found that the 24-hour urinary cortisol level was elevated, and also on dexamethasone suppression test the serum cortisol at 8 am was elevated. The normal range was less than 1.8 microgram per deciliter. It was 6.3 microgram per deciliter. So with this we had the diagnosis of cortisol secreting adrenocortical carcinoma in our mind. Since the patient had history of cerebrovascular accident 4 years back, we did one MR brain. In that we found there were 3 enhancing lesions involving the diploid spaces of bilateral parietal bone and frontal bone on left side, suggestive of calvarial metastasis. There were chronic lacunar infarct in the right basal ganglia region and foci of blooming in right insular cortex, and bilateral thalamocortical region, suggestive of microbleed secondary to long-standing hypertension. So, in view of the likely mets present in the bilateral parietal bone and frontal bone, we did one bone scan that was not suggestive of any bony metastasis. Pre-op, one echo was done of the patient, that was all normal. So, our provisional diagnosis for the patient was metastatic cortisol secreting adrenocortical carcinoma with hypertension. Patient was having large mass, probably arising from the adrenal, as shown in this 3D image. Following this, the patient was optimized and managed initially by the endocrinology team, and the hypertension was controlled. She was started on 4 antihypertensives, tablets aldactone, prazosin, amlodipine and telmisartan. And since due to the chronic suppression of her hypothalamus pituitary adrenal axis, at the time of surgery she was given injection hydrocortisone 100 mg IV stat at the time of induction, and in the peri-op period she received injection hydrocortisone 50 mg QID. Post-operatively, in follow-up, patients antihypertensives were stopped and are not required now, and steroids have been tapered to the physiological dose of prednisolone, that is 5 mg per day now. This post-medical optimization, she underwent endoembolization of the branch of the left inferior phrenic artery and left middle suprarenal artery, supplying the left adrenal mass by the IR team, and followed by left anelectomy was done by the urology team. The intra findings of the case was there was a large mass pushing the transverse colon and descending colon up with multiple parasitic vessels present surrounding the mass. The fat planes with the surrounding structures were maintained and left open adenectomy was done safeguarding all vital structures. It was a large mass of 20 cross 18 centimeter that was excised. The intra challenges in this case were it was a very large size vascular tumor of adrenal origin with multiple parasitic vessels. For that only we did initially angioembolization of this case, and the mass was also abutting adjacent structures like colon, left kidney and spleen. For the histopathological diagnosis, I will invite Dr. Samiksha from the pathology department to discuss the HPE of this patient.
Good morning, everyone, respected faculties and all the seniors here. So I am Dr. Samiksha from the Department of Pathology, JR2. So I will be presenting on the pathology. Okay. So the first picture is about the first picture is from the SMS staining of this tumor, and this is the 10x power. First one is the 10x power. So we can see the cells arranged in the diffuse sequence pattern. Okay. And the second picture is the 40x view. The same picture in the 40x view.
Pointer or cursor.
Okay, sir.
You can use the cursor or pointer.
So here, these are the tumor cells. Okay, all the cells here are medium in size, and you can see the nucleus here. There is a mild and isonucleus. There is not much more nuclear pleomorphism. However, there is only the mild nuclear pleomorphism. Some of the cells over here, these cells are large and having these prominent nucleoli. And these are also the nucleoli. These are the eosinophilic nuclei. According to the Furam grading, and these are the grade 3 nuclei, and that signifies more towards the malignancy. And some of the large cells can be seen here. These cells. So these cells are the large with the clear cytoplasm. So these are the clearing cells. You can see the clearing cells, and this signifies there is a high lipid content. Okay, and we can see this area. So some of the cells are showing the inclusions, like this. Here we can see the one inclusions, and here one inclusions. Okay, so this is as per the which criteria. No? So there should be some areas of the necrosis, like these areas we have a necrosis, and which criteria, what happens, there is a 9 categories. So among the 9 categories, 3 or more of the categories should be present, and that signifies towards the more malignancy. So here we can see the tumor focal areas of this necrosis, and nuclear pleomorphism having a prominent eosinophilic nucleoli, and mitosis is very important for this in order to grade it as a low grade or the high grade. So in this condition, we grade it as adenocortical cancer low grade. It is this low grade and high grade. It is based on the mitotic figure. So if we get the mitotic figure 20 or less in 50 high power field, then it is called as a low grade. So if we get the mitotic figure more than 20 for 50 high power field, then it is called as a high grade. So here we got only 7 to 8 for 50 high power field. So we diagnose it as a low grade. And immunohistochemistry was done, and this is the synaptophysin. So it came out to be diffusely cytoplasmic staining. Other than that, we did chromogranin. So in order to rule out whether that is a medullary or the cortical. So since in cortical tumors, this chromogranin, they are negative. So it rules out the pheochromocytoma. And other than that, we did calcitonin. So calcitonin came to be diffusely this nuclear and cytoplasmic positive, but I can't put the figure. And along with that, the chromogranin is negative, as 100 is negative. That also rules out the pheochromocytoma. So overall, the histomorphological and the ISC reading, we gave the conclusion is a low grade adenocortical carcinoma. Thank you.
Thank you, Dr. Samiksha, for the detailed description of the histopathological report. So, in the HPE report, it was an encapsulated tumor with suggestive of adrenocortical carcinoma low grade, and all margins were negative, and there was no lymphovascular invasion identified. And on ISC marker, Ki67 was 5 to 7%, suggestive of low grade disease. On follow-up of the case, the post-op period was uneventful of the patient. Patient was discharged on PAD 8 of surgery. At 3 months follow-up, she is comfortable with no complaints at present, and she is currently not on any antihypertensives. And on PET scan done at 3 months of follow-up, there was no uptake anywhere in the body. Following which, we also did one MRI brain to see what is the status of the likely mets that was given in the pre-op period that was suggestive of no calvarial metastasis now, with resolution of metastasis likely. So this was the MRI brain. As we can see, there was enhancing areas in the parietal bone, bilateral diploid spaces that has in the post-op MRI at 3 months, there is no enhancing region present. So now moving on to the discussion of the case, we will be discussing this case of the adrenocortical carcinoma, its workup and its management and follow-up. So the clinical presentation of adrenocortical carcinoma is mostly they are functional, 60% are functional, and 30 to 40% presents with non-specific symptoms due to abdominal mass, and 10 to 15% are incidentally detected by imaging. And among the functioning adrenocortical carcinoma, the most common functioning is the cortisol secreting adrenocortical carcinoma that accounts for around 3/4 of the all cases of adrenocortical functioning carcinomas. So as we have discussed, the imaging findings differentiate common adrenal pathologies. In this case, there was a significantly large mass and it was having irregular shape and margin and was heterogeneous in composition with hemorrhagic areas and necrosis in between. And percent washout was less than 60% absolute and less than 40% relative. So that was suggestive of adrenocortical carcinoma in this. Regarding the functional evaluation, once we have found that this is a likely adrenocortical carcinoma on imaging, we did the functional workup of the patient. So if for functional workup, glucocorticoid axis, sexual steroid and steroid precursor axis, catecholamine axis and mineralocorticoid axis is to be done. This is done by these tests as we have described: low dose dexamethasone suppression test for cortisol axis, ECTH, and rest of the testosterone, estradiol for testing for the sexual steroids, and serum and urinary metanephrines for the ruling out pheochromocytoma. Aldosterone to renin ratio is done in the patients with hypertension or hypokalemia. Moving on to the staging of the adrenocortical carcinoma, according to AJCC 8 staging, it is based on the size of the tumor and its local invasion, the nodal status and metastasis. So if it is less than 5 cm is T1, more than 5 cm is T2, T3 is with local invasion but not invading adjacent organs. Like if only fat is invaded, then we will call it as T3. T4 is that invades adjacent organs or large blood vessels are invaded. N1 is metastasis in the regional lymph nodes, and any distant metastasis come as M1. So according to stage group, stage 1 is the tumor that is T1 or T2, and stage 2 is the localized tumor, stage 3 is the tumor that are having nodal positive or having local extension, and stage 4 is metastatic adrenocortical carcinomas. Regarding the metastatic workup, the most common sites for distant spread of adrenocortical carcinoma are lung, liver, lymph nodes and bones. For this reason, CT imaging of the chest and liver as well as bone scan are typically included in the staging workup if an adrenocortical carcinoma is suspected based upon the initial evaluation and presentation. Adrenocortical carcinoma has a poor prognosis and survival rates of 5-year survival rate are around 60% for stage 1, 50% for stage 2, 20% for stage 3 and less than 5% for stage 4 adrenocortical carcinoma. The primary treatment of the adrenocortical carcinoma is the complete surgical excision. It is the only potentially curative treatment. In metastatic adrenocortical carcinoma, cytoreductive removal of the primary tumor is done if we can remove more than 90% of the tumor. It is important to identify cortisol producing tumor. These patients, even those with mild hypercortisolism, have some degree of hypothalamus pituitary adrenal axis secretion and require glucocorticoid coverage in the peri-op period and in the post-op period. All the suspicious lymph nodes should be resected, and the benefit of routine lymphadenectomy though has not been established yet. Patients with advanced functioning tumor debulking helps to control the hormone hypersecretion and also increase the efficacy of the further therapies. The chemotherapy that has been considered as the first line is mitotane or MEDP chemotherapy, that is composes of mitotane, etoposide, doxorubicin and cisplatin. It was based on the FIRMAC trial that was done. Moving on to the neoadjuvant therapy, the role of neoadjuvant therapy prior to surgery is not considered a standard approach in adrenocortical carcinoma. For deciding the adjuvant therapy of mitotane for the patient, there are three major prognostic factors that are to be included. One is the tumor stage, the completeness of the resection and the proliferation rate as determined by the Ki-67 expression. Low risk of recurrence is present in the patients with stage 1 to 3 disease and with R0 resection, and if the Ki-67 is less than 10%. High risk of recurrence is present in patients who are having high-grade disease with Ki-67 staining of more than 10% or more than 20 mitotic figures are present. And if there was not R0 resection was present in TROP, and if any intraoperative tumor spillage was present. In such cases, we give adjuvant mitotane therapy. In very high Ki-67 staining and extensive vascular invasion, we add cisplatin based chemotherapy to mitotane. Regarding mitotane, it is a congener of the DDT, a commonly used pesticide, and it is an adrenolytic corticolytic drug. It's for a high risk adrenocortical carcinoma, adjuvant mitotane is given for 3 to 5 years. The rationale for this duration is that it is very atypical for a patient with adrenocortical carcinoma to recur after 4 to 5 years. And for low risk adrenocortical carcinoma, observation is preferred for most patients. The therapeutic monitoring of the plasma mitotane level is advocated for every 4 to 6 weeks with a target of 14 to 20 microgram per ml. And mitotane is initiated at the dose of 0.5 gram twice per day and increased to 6 gram per day over 4 to 12 weeks as tolerated. So as the mitotane has side effects of hypothyroidism, so we have to monitor the thyroid profile of the patient, LFT of the patient, and electrolyte monitoring is to be done. So this is the recommended monitoring that is to be done during mitotane treatment. Regarding the follow-up of the adrenocortical carcinoma post-resection, the cross-sectional imaging is advocated 3 monthly for an interval of 2 to 3 years, and then less frequently at the interval of 4 to 6 months for 5 years. This is according to the clinical practice guidelines of the European Society of Endocrinology. Recent update of PET in adrenocortical carcinoma, there is a upcoming modality, metomidate PET, that can distinguish tumors of adrenocortical origin from the non-cortical lesions, but it can't distinguish benign from the malignant corticodelineation. Now we, Department of Urology, doing adrenal surgeries regularly with the help of our endocrine team, and we have done around 6 pheochromocytoma, adrenocortical carcinomas 3, adrenal myolipoma 2, and 1 sphenoidal liposome. These are the intra-op imagings of few cases that we have operated in the past. Thank you.
Thank you. Thank you, Dr. Umang, and the team Pathology and Radiology, and definitely team Endocrinology. So, a very good morning to all of you. So, basically, just to brief some important points regarding the case. So, this was the case discussed for adrenocortical carcinoma. So, what is important here is, so it is a teamwork. So, a very good teamwork between endocrinology department, urology department, other surgical specialties where we may require intra-op assistance. So the most important point is, the main crux is that whatever we do a workup, whenever we go functional workup in such cases, although we know the size criteria and everything goes in favor of cortical tumors, but we should never forget the small incidence of few in such cases which have also been reported. So every time if you see in the functional workup, we have done workup for pheochromocytoma to rule out. Even in pathology, our pathology division had emphasized they have done IFC staining to rule out, pheochromocytoma, because you may have an association of that too in such cases, although it's unusual. Second important point here is, whenever we find such cases of adrenocortical carcinoma, size is a very important criteria which comes in TNM staging. But yes, majority of time when we do an imaging, they looks like that they definitely such a big mass that you feel that whether you will be able to do an arterial resection or not once you go in. But the guideline they suggest that even if you go inside, you should always give an attempt, because the only management of adenocortical carcinoma is surgical excision, which can do good to the patient. So always the attempt of surgical excision with the teamwork is always made. Even if you are not able to do an arterial resection, if you can do more than 90% of tumor debulking also, which is sometimes called as cytoreductive surgery in case of adrenal, it's also beneficial to the patient. Fortunately, in this case, when we went inside, we were able to do an arterial resection in this case, and patient is doing fine. The third important point which we can emphasize through this case is, we have seen several cases of spontaneous resolution of metastasis in case of renal masses. So when we do cytoreductive nephrectomy in case of metastatic kidney tumors, it has been reported that we have spontaneous resolution of metastasis in those cases. So as we see in this case, which was very good for the patient, that she was a case of metastatic adrenal cortical carcinoma, and on 3-month follow-up, when we did the MR and the SPECT-CT, the site of metastasis, there is spontaneous resolution documented on imaging. Although it is a very short follow-up, we need to follow patient regularly as per follow-up protocol described by Dr. Umang. But see, this surgery has helped the patient that there can be spontaneous resolution of metastasis too. So this is again third point which goes in favor why the guidelines have suggested that surgical excision is the treatment. And then the most important point is consideration of adjuvant or neoadjuvant mitotain and other chemotherapy agents, which need to be used judiciously after due consideration in tumor board, discussion with medical oncology and other teams, and need to take a collective decision, which has been done in this case. As of now, this case, as documented as low risk disease, is kept under follow-up, and we are right now not considering for mitotain, and they are discussed together, and we will keep this patient under follow-up and see how this patient behaves. Good prognostic factors in this case is low risk disease, as documented on pathology, and arterial resection. These 2 points are good prognostic factors which we always tell our patient that, okay, these are the things you can have a good course. Although we understand the 5-year prognosis in adenocortical carcinoma is not very good. But I think it's the time that we follow this patient very stringently, and that will tell us. So I think, thank you Dr. Oman and the team.
Any question?
Any questions from the house? I open the house for discussion, please.
You can come back.
Thank you, Dr. Umang. That was a very good case, very well worked up case. But there's one doubt which I always have as an oncologist. How do you know that the lymph nodes are not involved? And why did you not address the lymph nodes? Even though radiologically they seemed normal in size.
So whenever we deal such cases of adenocortical carcinoma, imaging is a very important tool which we use sometimes some incident imaging that the lymph nodes were not there on imaging. But definitely when we do intraoperatively, we always again see for it, right? And in such cases where you have a metastatic disease, because it was metastatic adenocortical carcinoma, we have a documented case. So as per literature which we have reviewed, and we know, if there are palpable lymph nodes intraoperatively, it's always good to remove it. Proper lymph node resection in case of metastatic adenocortical carcinoma, as per now, is not a line of treatment. But yes,